Hello, everyone. Welcome from Innsbruck, where we have the headquarters of MED-EL. I'm glad that I can host this Experts Online. It is on the Bonebridge, and the title is Innovation and Design Impacting the Legacy and Future of Implantable Bone Conduction Hearing. First, I want to give you some participation tips. It would be really nice if you name yourself and the organization so that we know who is asking questions. To avoid background noise, please mute your microphone and also mute your phone. And for a stable internet connection, it might be advisable to close all other programs. We want to make it interactive, so if you have questions, they are welcome. Just raise your hand. We also offer English captioning available that you can put on closed captivation. So if you press there, you can have captioning. And I said already, we want to make it interactive. So we have included some Mentimeter questions. And you have two options how to join Mentimeter. Either you can go on www.menti.com and press in the 60, 40, 26, 74. Or easier, you scan the QR code and then you immediately get to the questions that we have prepared. So, whoops, suddenly the presentation jumped all around. So this session, I am Christine Müllecker. I'm the moderator of this session. We have several speakers. We have first Kevin Vukovic. He's the Director of Bone Conduction Systems at MED-EL Corporation in the USA. And in the second part, he will take over and interview two customers from the US, so two American surgeons and audiologists. One is Oliver Adunka from the Ohio State University, and the other interviewee is Dr. Saul Strieb from the Nationwide Children's Hospital. But more information on those two will come later from Kevin Vukovic. So here comes the first Mentimeter question. What time is it now in the place you are at? And I think it's nice because I guess we will see quite some international participation here. And I guess we have a lot of different time zones in this Experts Online. So here again, the Mentimeter code or the QR code. So I see already some is 3.3. 3 p.m. or very early in the morning, like 8 a.m., 9 a.m., 9 a.m. So most have 3 a.m. So I guess a lot of European listeners are also within this Experts Online. So thank you so much for voting. Please keep this Mentimeter because we will have further questions later on. And then I want to go on with the presentation. I want to start with the mission of MED-EL. Our mission is that we want to overcome hearing loss as a barrier to communication and quality of life. And we effectively yet gently restore hearing by offering a comprehensive set of intact skin hearing implant solution. And this intact skin hearing implant solution is important to us. And now I cannot forward, sorry. Can someone help me so that I can forward the slides? Thank you. So the Bonebridge that we offer now is the second generation Bonebridge implant and the third generation audio processor. So we have the Samba 2 that is small and light, and we have the BCI 602 that offers intact skin and direct drive, which is a very effective way but still leaving the skin healthy. The indications are as shown here for conductive hearing loss and mixed hearing loss. Bone conduction can go down to 45 dB. And for single-sided deafness, the contralateral ear should be within 20 dB, while the affected ear is deaf. Indication regarding children is 5+ in Europe and 12+ in the US. So what does Bonebridge offer? We have 10 years of experience with this intact skin implant. So we have long-term experience, and this experience showed that we are very reliable. We have for the BCI 601, the first generation, a reliability rate for device-related CSR from 98.02% at 9 years, and this is including impact. And for the BCI 602, at 2 years, we are still at 100%, including impact. We offer an implant that gives stability and is impact resistance due to the fact that it has a recessed transducer. So you drill a bed where you can recess the transducer, and it is fixed with 2 screws so that it's really tightly embedded in the bone. Our implant harmonizes to the anatomy of the patient and also to the surgeon's need. So we deliberately look to have an ergonomic design so that it does not push too much against the skin. And we kept the bendable and flexible transition so that the implant can really be accommodated to the patient's anatomy regarding BCFMD placement, but also regarding the coil placement, because the coil should be in the position where it is best situated for the patient. And we offer a really long battery life of 8 to 10 days with 1 single battery. And this is very important if it comes to countries where patients have to pay for the batteries. And also we have MRI, we have easy MRI, which means peace of mind for the recipient if they need an MRI. So now I mentioned already, we have the 2nd generation of Bonebridge implant, the BCI 602. So it is really the worldwide first active transcutaneous bone conduction that is already in the 2nd generation. And very important, we have backwards compatibility. So our patients who were implanted 10 years ago with the BCI 601 can now take the benefit of using a Samba 2 audio processor. And with this, I want already to introduce you to the first speaker. As I said, it's Kevin Vukovic from Med-El Corporation in the USA. And he will talk about his experience. He's a bilateral user, a bilateral Bonebridge user, and he will talk about his experience from a patient's point of view. And as he has maximum conductive hearing loss, you can imagine that he had quite some challenges before. So please, Kevin, the stage is yours.
Thank you, Christine. I greatly appreciate the opportunity to share my story and my experience with Bonebridge, and then ultimately how working with bone conduction implantables is impacting the population very much like myself with maximum conductive loss, as well as those with mixed and conductive or single-sided deafness. I like to start my presentations by taking a step back and asking the audience, what is your why? Why are you passionate about hearing healthcare? Why are you sitting here today with us? What is it that you've experienced perhaps in your life with family members that have had hearing loss, or something ultimately compelled us to move forward and focus on making a difference in the lives of others with hearing loss? And for me, it's this. This is my maximum conductive hearing loss. This is what my preoperative audiogram looked like and continues to look like. My hearing has been stable to that extent for many years. As the audiologist in the group will see, I am your worst nightmare with the masking dilemma as far as testing in the booth. But you know, my history is one of those complex that only a surgeon could love, because I've had a little bit of everything with cholesteatoma, eustachian tube dysfunction, disarticulation of the articular chain, the chronic perforation on my right side. That's actually my right eardrum, or what's left of it. You could say 75% perf, you could say 100% perf. There's not much there, but this is my reality. And along with that is my surgical history. I had multiple sets of PE tubes as a kid, probably 4, 5, 6 sets. We lost track. Whether they would last a day, a week, a month. There was no consistency to it, just the way my anatomy took to those tubes. And then ultimately that resulted in tympanoplasties. I had multiple failed tympanoplasties, both cartilage and cigarette paper, the last of which was sometime in the 80s. That involved the canal wall down mastoidectomy as well on my left ear to deal with the cholesteatoma. But thinking about the amplification history and how this has evolved over the last several decades, I was first fit with the BTE in 1983. And at that time, the school of thought in amplification was one ear is enough. And so I was fit with just the right ear, although my left ear looked very similar then to what it does today. And that was through junior high and high school. By the time I got to college, it was very noticeable that I wasn't doing well in that larger environment. And the fitting philosophies had changed, where now binaural was the standard of care. So I graduated up to a binaural fitting with BTEs. I've graduated from the analog to the digital potentiometers to programming on the laptops. And I've seen this evolution of the hearing aid technology and continued wearing those until 2019. But taking a step back from my history and looking at the history of bone conduction amplification as a whole, starting in around 1950 and progressing over the last 70 years or so, we've seen some evolution, not great leaps and bounds, until about the last decade or so. And really what's happened with this introduction of Bonebridge is, as Christina mentioned earlier, previously you had a choice of either intact skin or direct drive to bone, but you never had an option that married both solutions. So when I first started looking at potential options around 2009 for myself and listening to what was available then on the soft bands, and as the audiologist, appreciating that what I'm hearing on a soft band isn't necessarily what I'll appreciate with a direct drive to bone system. I mean, these were all things that I had to consider, and the audiologist in my professional training and experience in the clinic really let me know what the reality was. And, you know, the safety outcomes white paper that MED-EL has published, this meta-analysis of the data that's out there and looking at the complication rate for these previous generations of technologies, and me being so intimately involved in working with the hearing impaired and implantable devices, I knew what that complication rate was. And that's really what made me hesitate. So ultimately, I waited until Bonebridge delivered this intact skin and direct drive to bone. And coincidentally, I ended up working for MED-EL, but this was totally unrelated. I just serendipity, I guess, in the fact that ultimately I ended up working with the company that has innovated and delivered on something that was what I'd been looking for as far as the hearing healthcare solution. I was implanted 3 years ago this month, bilaterally, simultaneous. And ultimately what that means is I was implanted with the BCI 601. I knew the BCI 602 was coming, but I also knew that, well, one, I had waited as long as I had, but two, there was no significant difference as far as output. We weren't making any compromise or improvements. I was still going to get significant benefit regardless of whether the 601 or the 602. So I chose to go ahead and proceed. Now, that being said, I've had the luxury of being upgraded to the Samba 2 Bonebridge. And that was a seamless process for me. I was implanted with the first generation implant, but now I have access to the third generation audio processor and all of the technology that comes with that, from the connectivity with the Samba to Go to the scene analyzers. And for those who may not be aware, the addition of the car scene analyzer, at least for me, with the new technologies that were available with the Samba 2, the car scene analyzer has been a game changer. I've never heard as well in a car with my amplification as I do with my Samba 2. And that's over 35 years of experience wearing different brands of hearing aids and different configurations and things like that. My Samba 2 has truly delivered something that, in a very challenging environment of driving a car or being in a car with road noise and ventilation, people talking, music on, it's a very frustrating environment for somebody who's wearing amplification. And I can truly say now that I'm much more comfortable in a car because it's not as stressful of an environment, and I'm not having to work as hard to hear and truly enjoy conversation with others in that car. So to give you a sense of how quickly I progressed with my Bonebridge, my surgery was March 29th of 2019. I was activated 12 days post-op, and that's one of the beautiful things about the intact skin solution is you do not need to wait for osseointegration for activation. So I was activated 12 days post-op, and then 1 month after that, I came back and was tested and was already testing out at 96% on the right ear and 88% on the left. So very happy with the outcomes and just the acclimatization to the fact that I no longer have feedback that I had lived with for over 35 years. No longer have circuit noise from power BTEs. My acclimatization was learning what quiet was. I had forgotten what quiet was because whenever I was wearing amplification, there was some type of distortion or background noise, be it feedback or circuit noise. So, with all of that and sharing my experience, I now want to bring in our colleagues and guest for today, Dr. Oliver Adunka, who is the William H. Saunders, MD, Endowed Professor at the Ohio State University, as well as the Vice Chair of Clinical Operations, Division Director, Otolaryngology, Neurotology, and Cranial-based surgery. So in addition, we also have Dr. Saul Strieb, Audiologist, who is responsible for both the Audiology program and the Vestibular lab coordinator. Both of them bring a wealth of experience and knowledge on implantables, specifically bone conduction implants. And with that, I would like to open this up to kind of an interview portion where we can get to know both Dr. Adunka and Dr. Strieb and gain some insights into their experience with Bonebridge and bone conduction implants as a whole, as well as the program at the Ohio State University. So, Dr. Adunka, if you'd like to go ahead and just kind of share a little bit about yourself and your passion for hearing healthcare, as well as
Sure.
kind of your background. So I'd appreciate it.
Yeah, thanks, Kevin, and thanks, Christine, too, for the nice introduction. And Saul and I are thrilled to be here this morning, or afternoon for some of you guys. So again, thank you for joining us here. So yeah, we're at Ohio State University. It's in Columbus, Ohio. For those of you who are outside of the United States, it's in the northeastern part of the United States. It's a large hospital, and we're actually talking about two hospitals. We're at the Ohio State, and we have a separate children's hospital. It's our Department of Otolaryngology is about 50 faculty, so 50 faculty members. We have 5 residency slots every year. We have a accredited neurotology fellowship, and there are 4 of us who practice neurotology. So we're, I think, offering the entire spectrum of neurotologic care, including lateral skull base. We're a large cochlear implant center. And again, we've really sort of enjoyed really switching our bone conduction practice pretty much away from the percutaneous devices that were flooding our clinics, like you showed earlier, Kevin, with a lot of the clinic visits right after the fact for infected posts, especially in a population that's a little more obese than probably some other parts of the world, right? We saw a lot of skin complications from BAHAs. And of course, the manufacturers have helped us with HA coating and all that, and longer abutments, but we still quite frequently saw those patients, right? So we have started doing Bonebridge. I believe I did my first 2 Bonebridges. I remember that it was, yeah, I think in December 31st. I remember it was the last day of the year, and we added 2 on. I believe it was in 2018, I believe, and we, you know, it was the 601 device. Obviously, as Kevin pointed out, very different devices and surgically very different devices, right? It was 8.7 millimeters deep, I believe, right? So it required quite a bit of maneuvering in that area behind the ear. I remember the very first case I did was actually a golden Haar patient, so a patient with golden Haar syndrome, and she was 15, but you know, her head was quite small. So I'm like, I remember my former fellow at the time said he didn't know we had a skull base case on today, so obviously had to really dig down all the way to the Dura. But it was, you know, needless to say, the 601 required some real surgical skills, I believe, to get the device in, get it anchored properly. You know, obviously the screws were not self-tapping, so there's required a lot more work. But you know, we immediately saw the benefit that patients really liked, and that first patient I just talked about, she used to have a Baha, and we kept converting a lot of patients again away from the percutaneous options to the transcutaneous options, right? And so that's really been sort of the story here, that we've done a lot of conductive and mixed losses with it, right? As you showed your own audiogram, right? I mean, I think Saul would caution. I always, when I have a patient in clinic, I always come over and then we look at that cochlear reserve, or we look at that bone line, and like you said, there's a masking dilemma, and there's certain complex aspects of getting good data that is really critical, right? So I think Saul can talk some more about that topic, you know, and how much cochlear reserve the device can overcome and all that. I think, but you know, really, what kept us, you know, moving in the direction that we did was really patient driven. Specifically, a lot of the patients that we converted said, and they were, again, a lot of them were on percutaneous options for most of their life, right? They said, oh, the fidelity of the sound, right? The quality of the input is much improved, right? And for me, the combination of that with a transcutaneous option where we didn't have to worry about the skin flap, right? As opposed to a Baha tract, for example, was something that was really attractive. So I think, and people ask me that all the time, and I'm like, well, I just do what's best for my patients, right? And I really felt that was the better device in terms of overall patient satisfaction, right? And if you will ask any physician or audiologist, right, if our patients are happy, then that certainly makes for an easy clinic visit. And so that was really the driver in this transition for us, right? So
Oliver, may I ask you, you said that you have converted a lot of patients to the Bonebridge. Did you have any special things that you had to look at, like where the abutment was before, so that the Bonebridge does not interfere with that place?
Yeah, it's a great question, and every patient's a little different there, I would say. What I try to do when I convert folks, I like to remove the abutment in clinic, right? So in the office, let it heal over, and then bring patient back for surgery. So ideally, I don't have to deal with the abutment during surgery, or the skin, the hole basically in the skin, right? The percutaneous.
So how much time do you have in between?
Sometimes it's just a few weeks, right? So sometimes I book people, and we take it out 6 weeks prior. Some folks, we have actually removed everything, the abutment and the implant, at the same time that we do the Bonebridge. We had some concerns about an infection in those cases, right? Where you had where the abutment was chronically infected, had a biofilm, and then we were concerned about putting another implant in, right? So I think that was a concern. But generally speaking,
in those cases, did you make sure that the coil of the Bonebridge was not close to the former abutment?
Yeah, so what I would say is that we always try to remove not just the abutment, but during surgery replacing the bone bridge, we usually try to remove the implant of the Baha as well.
Okay.
And sometimes that's not trivial, because if it's really osseointegrated, it's in there, and you have to drill it out all the way to dura, right? So I think that removing of the Baha can actually be harder than putting the new bone bridge in, especially the 602. So we felt that if we convert people, we do like to remove the old implant, right?
Okay.
All of it, right? And a lot of patients actually requested that, right? And where the Baha is usually placed, it's either close or it directly interferes with the new device. So I think that was sort of one of the main things. But yeah, removing for us, it was, you know, the step that I outlined earlier to have the skin be closed before we you know, enter the operating room with the new bone bridge. I think that was for us an important step.
So do patients feel it if there was a abutment before in the place where you have later on the audio processor?
They do. Usually there's a little indentation, and it depends on when the Baha was done, right? I mean, I remember like 20 years ago, we used to chop off a lot of tissue back there into the muscle, right? With the newer Bahas, we haven't really done that anymore. So it depends on when patients were really implanted and how thick is their skin flap, and you know, if they're obese or not. But so it really depends. If you just remove the abutment, usually there's a little indentation. It typically doesn't bother most people as long as that indentation doesn't interfere with the receiver of the bone bridge, you know, the coil portion. I think that was fine. On some people, we actually ellipsed out the skin of the Baha and closed the skin primarily, just to make it flat again. So we have done that as well. So there's several techniques. It's I would say it's highly dependent on the particular patient.
Okay, thank you.
Perfect. And now, Saul, similar question to you as far as your experience and just your passion for hearing healthcare, becoming an audiologist and working with an implantable or candidates and recipients of implants, be it CI and then bone conduction. Share a little bit with the audience and give them a sense for just your background, if you would, please.
Hey, thank you. Thank you for having me today, and I'm glad to be here. I've been an audiologist for 21 years. I got into it because I was exposed to some loud sound as a musician, actually playing in bar bands, and had my hearing monitored and just decided it would be a career that I'd want to get into. So anyway, I worked at a hospital in Washington, D.C. for 10 years, mostly adult patients, and then came to OSU in 2011, and I've been here since then. I've worked with bone conduction implants pretty much the whole time I've been here at OSU. The earliest ones were the Bahas and the Pontos, because that's what was available at the time. And then I think 2019 is when I started working with the active transcutaneous implants, first the bone bridge, then the osseo later after that. But most of what I've done as far as these implants has been are concerned is the bone bridge devices.
Perfect. Well, we're going to shift gears just a little bit and move into some audience participation. We have a few poll questions that we will kick back to the Mentimeter for. If you guys pull up your Menti. And for those who weren't with us earlier, you can either scan the QR code or go to menti.com and enter the code that is there on your screen. But truly, scanning the QR code is probably the easiest, as we found during the pandemic if we go to restaurants. Okay, and which features of an active transcutaneous bone conduction implant are most important to you when counseling a candidate on the technology? Okay, thank you all. Looks like we have about 16 people who have responded. We'll keep an eye on it, get a few more responses. It looks like we're pretty evenly distributed between, actually outcomes jumped ahead there. Outcomes, reliability, and then MRI seem to be the most prevalent of features that professionals are focusing on when counseling candidates for bone conduction technology. Thank you for that. Let's go ahead and switch to the next question. Okay. Similar question, but kind of taking a different slant. Which features of the active transcutaneous bone conduction implant are most important to your patients? What are the candidates coming in and asking for, or seem to be focused on mostly when looking for a bone conduction hearing solution? Okay, we have about 10 people that have responded so far. Give it another few seconds for others to respond. Looks like we're pretty evenly distributed across connectivity, outcomes, and reliability. Perfect. Okay. And then specific to Oliver, asking a follow-up question for this with regard to MRI. Have you had experience where you've had to, with Bonebridge, as we know, you don't have to have the magnet removed for MRI, regardless of where it is on the body. Have you, with other systems, had to remove any magnets? And what are your thoughts on that type of scenario for these recipients?
Yeah, so some folks who had acoustic tumors who require MRIs as a just routine follow-up, right? We've implanted bone bridges, and I think you have to, establish a conversation with radiology to improve patient positioning in the scanner, et cetera. But with that being said, we had quite a few patients who received MRIs after bone bridge surgery, and the ipsilateral internal aortic canal is still visible. So I think it just requires a conversation with the radiologist and especially the technician who actually performed the scan, just to get it properly, the patient properly aligned, and just provide some education, right? But with that being said, we still get, despite our counseling, goes to show what actually arrives in some patients, in terms of the counseling preoperatively, and they still call after surgery and say they need an MRI, and they felt they can't have it. And our assistants and secretaries and nurses usually just clarify that with them. But again, in-house radiology is important to provide that kind of clarification.
Perfect. And yeah, recipients, and I know this personally, but we do receive an indications card that does provide instructions for MRI, and then MED-EL does have resources on our websites as well internationally to provide guidance to the radiologist. So we certainly are prepared to assist you guys with that.
Yeah, but we really haven't had an issue, and for us, it was one of the main, I think, factors of why we sort of endorsed the Bonebridge more than other devices. Having that MRI compatibility on board was critical for us.
Perfect. Well, thank you. And so this is the portion of the presentation where I will turn control over to Saul for the slides, so that Drs. Adunka and Strieb can share the experience and just some of their findings with regard to utilizing Bonebridge in their clinical environment.
So these are just some of the main reasons that we advantages that we see of the active transcutaneous implants over the passive ones. And Dr. Adunka has already talked about the low risk of infection and inflammation and skin overgrowth, and the shorter time post-surgery until activation, and MRI compatibility. From the audiologist perspective, one of the things that I'm definitely noticing is that we can get higher gain out of these devices before we get feedback, so higher stable gain. They're generally easier for the patients to put on, although one thing I'll say about that is that I'm very pushy about having the patients use their hair or clothing clips when they use these things, because I did have a patient that they were not using it and they lost the device, although they subsequently found it. So, but I get real pushy about that because there's no actual physical attachment, it's just magnetic. And then, you know, I think patients appreciate the improved cosmetics they get from these devices due to lower profile, that they have no visible abutment when they're removed, and then the fact that the covers are changeable is appealing to some of the patients. And the long battery life is a real seller for this device, because when I'm putting all the options out there for them in an evaluation, and I do mention battery life there, and it's a lot of patients look at the longer battery life of these devices compared to some of the other ones, and that can be a deciding factor for them as well.
And I think just from personal experience, knowing that streaming or connectivity with the Samba 2 Go and the Bonebridge or the Samba 2, it does not negatively impact that battery life as well. So regardless of how much, and I'm actually using my Samba 2 Go right now for participating in this event, I still know that I will get 8 to 10 days regardless of how much I use. And I'm on these video chats or phone calls pretty regularly throughout the day. One follow-up question I have for you guys is the shorter time post-surgery until activation. Do you find, now that you're not having to wait for osseointegration with intact skin and direct drive to bone married into one device, how is that changed your protocols or your clinical management of these bone conduction recipients?
Well, it's certainly improved, right? It's certainly, you don't have to wait 3 months to turn a device on. So, I mean, patients do like it. You know, I think inherently the human being is impatient. So I think it helps overall. But I mean, I don't think it's a huge factor, but it's definitely part of it. Saul, any thoughts?
I mean, I feel like patients appreciate the shorter time period. I don't know if it's as much of a deciding factor in their decision to go with these as with other devices that they might be able to get. I kind of doubt that, but they appreciate it. I would say that there have been some patients where we were able to actually do the activation despite the fact that there may have been still some soreness around the incision site, because where the processor goes is, if I'm remembering correctly, it's above where the incision site is, as opposed to, say, the Bajas and Pontos, where, you know, if they were still sore around that area, or if it hadn't osseointegrated completely, then you would want to wait longer. And so I think that not only is the waiting time shorter, but the ability to actually activate the device when it's expected to be activated is more likely to occur when with these devices than with some of the other ones.
Perfect. Thank you. I appreciate that insight.
Oh,
There may be a little, there you go. Yeah. Sometimes there's a little bit of lag on the change. Yeah. There you go.
So just about our evaluation for devices in general, there's two types we do. There's the single-sided deafness evaluation. So this would be for like patients with acoustic nerve tumors that are removed, or sudden sensorineural hearing loss for a variety of reasons, who just cannot use a device putting sound into that ear, or possibly they could. And we do want to explore the option of hearing aids if there might be a chance that they could use a device on the poorer ear. So I'm a big believer in getting binaural amplification at all costs if it's feasible. So, and the way the audiologists approach this is primarily through demonstrations of different options. So we do an audiometric evaluation, they do a surgical consultation, and we discuss the different options that are available to them. That would be the cross, bicross, the hearing aid, and in some cases, and then a cochlear implant. And I never assume that a patient will not be a candidate for a hearing aid. I had a patient the other day who had 0% word recognition score. She tried a cross demo. She did not want to go with the implanted device option, but she tried a cross option, didn't like it at all. I put a hearing aid on her ear, and she just liked having the awareness of sound so much on that side that she's probably either going to go with that option, or she's going to consult about a cochlear implant on that side, which may be kind of hit or miss in terms of getting it covered. But she really liked, even though I think if she can't get a cochlear implant, then she would probably go with a hearing aid on that side, just because she liked the awareness of sound on her bad hearing side so much.
And I guess that brings up the question then, since I know MED-EL was the first with the FDA approval for the indication for SSD for CI back in 2019, have you noticed a shift in either your clinical protocol or just the expectation for patients when they come in that a CI may be an option, where previously, because the indication wasn't there and insurance wouldn't pay, as you noted, that perhaps you're counseling patients differently about what their options are?
I mean, I'm mentioning cochlear implant. Very often they've seen the surgeon already before they see me, so they may have discussed it with the surgeon already, and then I will mention it as a possibility, but they need to talk to the surgeon, and their insurance needs to be investigated more as far as coverage is concerned. It's more of an issue here than in some other countries, obviously, where it may be kind of more routine for that kind of thing to get covered. But certainly, if I think it might be a possibility, I'll suggest they discuss it with the surgeon and then have a cochlear implant evaluation.
Okay. And then
maybe from a surgeon's perspective, I think obviously the two main indications for conductive mixed losses and then single-sided deafness, right? If I had to choose one as a surgeon, of my favorite, it certainly would be the mixed losses or conductive losses, right? It just works better. I think more and more a preference for single-sided deafness is to provide that cochlear implant to really provide ipsilateral input, but certainly we understand that a lot of bone conduction devices are brought in for single-sided deafness. I think it's less and less of something that we utilize, and frankly, we had some patients who were implanted for SSD, and really the subjective benefit is limited, right? So we love any kind of bone, and that's just not exclusive to the Bonebridge, right? That's across all bone conduction devices, but we use it less for single-sided deafness than we use it for the other indications I mentioned previously.
Right, and I would agree with that. That it just doesn't overall work as well for single-sided deafness as it does for conductive mixed hearing loss. It's usually just I can really count on it working for that. Whereas single-sided deafness, I really rely on the demos that we do to help the patient make the decision about how they want to proceed. And if the patient has significant hearing loss in their good ear when you're doing single-sided deafness, if they may be like approaching or a little bit past the candidacy guidelines, then I'm going to start recommending bicross at that point, because they're going to need amplification in their good ear at that point. So I think, again, it's about what's going to fit their hearing loss best, in my opinion, as the audiologist.
Yeah, for those candidates, my saying has become, they won't grow into it, they'll grow out of it, as that bone conduction or that central neural component deteriorates over time. So given that, there are the acoustic neuromas and others perhaps where the nerve doesn't innervate and things, any tips or tricks for pre-op counseling and helping set realistic expectations for that population? Because as you've noted, they do tend to be the more challenging of the bone conduction recipients we see. Anything that you found that tends to set it up for a better outcome, or at least more realistic expectations that you guys have utilized?
Well, so I want to first say that, just in my last comment, I don't want to downplay the fact that, I don't want to cover up the fact that I have a lot of patients with these things who have single-sided deafness who like them. So, but the ones that do best tend to be the ones that have really kind of normal hearing across the board in the good ear. So that's when it works the best. And so the question of how do I counsel them at the beginning? I mean, I basically, without trying to scare them away from the option, I'm basically saying if you get an option like this or cross, you're not going to have binaural hearing. You're going to have unilateral hearing, but the device is going to help you to hear sound on your good side. What that means is we don't expect much improvement in noisy situations, and we don't expect much improvement in sound localization. So, I will tell them that you may be able to tell which side of your head the sound is coming from just based on the difference in quality of sound, but not that you're going to be able to close your eyes and point to where the sound is coming from. And I stress that because I don't want them thinking, and then I'll say, a cochlear implant, or if you can use the hearing on that side, that's where those two things would probably help you more. They would give you sound coming into that ear so you could hear sound on that side, and you would probably be able to localize a lot better than with one of these other type of devices.
Okay. I mean, I think Saul brings up very excellent points here, and I think the proper counseling and not promising the world from single-sided deafness use, right, is critical, and a really extensive trial, right. We used to, like 20 years ago, when we did these first BAHAs for single-sided deafness, or we just put the Southband on patients and have them get a coffee downstairs in the cafeteria and then come back up, and they all loved it, right? But the problem, if you really send folks home with it for about a week or two, right, then they'll have a more realistic expectation of it, right? I think, and that's really has been our kind of process, right, to have these extensive trials, and then patients come back and they can actually distinguish, hey, I like it for this situation, but not that. So that it basically they're not going in blindly into this kind of process, right, and the procedure. So I think that's really something that we really stress to have an extensive trial.
Perfect. Thank you.
So some of the things that we talk about during the SSD evaluation is just the advantages, disadvantages, and benefits of each option, how they work, how long I have to wait for activation following the surgery, the cost and insurance concerns for each option, how the wireless accessories work and how they look, the color options if there are color if they need to consider that, and then there are other things that we talk about as well.
Okay, we're going to add in another poll question here, a little more audience participation. Just take a second to switch back over to the Mentimeter. Okay, so which assessments or questionnaires are you using in your practice to document benefit from bone conduction implants? And we have 6 options here, the 6th being other. So if what you're utilizing is not listed, if you would type that into the chat to share with the group, we would appreciate. Perfect. Nice. Looks like predominantly the Freiberger monosyllabic word test or the German Oldenburger sentence test tend to be the leaders in this. Thank you all for your feedback on that. The next poll question, please. Okay. What more can be done to educate professionals to assist with overcoming the perception of complications related to legacy bone conduction implants? So be it e-learning or webinars, research studies, and podium presentations at scientific meetings, or in sharing with other outreach groups, print materials, podcasts, blogs, and then again, the option for other, if you have thoughts or ideas specific to things that you're utilizing to educate the candidates. Okay, perfect. A lot of good feedback here.
Maybe I can chime in here, Kevin. So
sure.
I think it's really helpful for us as clinicians, both on the audiology as well as the physician side, to having demo devices in clinic, that you actually can feel and touch, and the patient can get a better sense of what's actually implanted in them. right? So I think it's always nice if we first talk about a Bonebridge. And again, most patients have chronic ear patients, you know, they're like your own journey, right? They've had procedures and frustrations that come with it, right? And I think having them, you know, talked about a new bone conduction device, you know, such as the Bonebridge. I think it's always nice to have that demo in hand, just to talk to them through the skin issues and all the other related concerns is really critical. And I think hearing them from audiology as well as from us, right, having a proper kind of team approach, I think is critical, and that's really one of the main reasons Saul and I are both here today. And so I think you know, proper education, sitting down with the patient, and you know what I sometimes do, I get into your website, I pull it up on the clinic computer, and you know, I write it down for them, or print some information out. Sometimes they want to see a YouTube video, right? And that's fine. I mean, the information is just so freely available these days that you know, it's just having a well-educated patient makes our life so much easier down the road, right? Because if there are no surprises, then you know, I sort of view it as front-loading that counseling workload in the preoperative space is absolutely critical for us.
That's a solid point. And I think resources too that MED-EL offers with our engagement team and then our hear peers. So those of us like myself who are living with and have gone through the process that can share what it's like, so we can match up candidates with those recipients, or those candidates, matching the candidates with recipients in order to just help set those realistic expectations and get more toward that outcome that we're all looking for ultimately. So
I think that's an excellent point, Kevin. And we see this with our cochlear implants, especially pediatric cochlear implants, you know, that you often want to talk to another family who just recently went through that, right? And Saul and I can say it all day, right? But hearing that from a peer is very powerful. And so I think that's a great point.
Thank you. Okay.
So just to kind of quickly go through the things that are included in the eval, we demo options. You know, we'll demo up to 3 different options that are listed there. The Baja or Ponto, we use, or an adhere in place of the Bonebridge. Then we could demonstrate a cross or a bicross and hearing aids. We do aided testing as part of the evaluation. For the single-sided deafness, that's words in quiet with their good ear covered and plugged. And then for conductive mixed loss evaluation, we also add in speech and noise testing, because that's where one of the places that we expect people with conductive mixed hearing losses to improve with when they add a second ear. So we want to show that and see how they do there. Our verification methods are pretty similar to what we're testing for when we what we're doing in the evaluation. We do the aided testing. In addition to this aided testing, we're going to add warble tone testing to see what the frequency gain characteristics of the device are, and if there are any adjustments that we might want to make to the programming related to that. We also use the COSI, client-oriented scale of improvement, and the Bern single-sided deafness, that's for single-sided deafness indication. Kevin, are you able to change the screen here?
There you go. There you go.
Thank you.
Sure.
And we can go on one more there. Okay, so for when we do the quick sin, so the quick sin, we're presenting speech, the target speech at 90 degrees towards the ear that's going to be implanted with and without the device on, and then we're putting babble into the good ear, or the one that's not going to get the device, at a varying level. And then we look at, we're looking basically for a signal to noise ratio 50, where they get 50% of the words, and then subtracting it from the score from normal people, and that's called the signal to noise ratio loss. You can read more about the Quicksin test if you want to know about that one. If we're doing binaural implantation, we do that on both sides. We kind of reverse it. from one side to the other, the way we'd do it for a single-sided one. We do have a couple of cases here. This is someone who was, she was sequentially implanted with bone bridges. First the left ear, I believe, then the right ear. She had congenital perfs in both ears, bilateral canal wall mastoidectomies, the last one at age 13, used hearing aids, was getting a lot of feedback with her hearing aids. I remember her saying she works as a school lunch lady, so it's very noisy where she works. This is her unaided, this is her unaided audiogram. So lots of masking dilemma there, even with insert phones. Her left ear was closed up at this point. One thing I'll say is that, you know, I think that even if you didn't have her exact bone conduction thresholds here, doing Weber's is good, because if you get a Weber on one side at one frequency, sorry, Weber test, if you get that on one side at one frequency and it goes to the opposite side on a different frequency, you know that the loss is at least mixed on both sides, and they would be a good candidate for binaural in that case. So a lot of times when we don't know with these conductive losses exactly which side is hearing the sound. When there might be conductive losses on both sides, they might kind of hear it on both sides or the middle, depending on where the sound is coming from. It might not localize or lateralize like it would for someone with normal hearing, for example. But still, the patients appreciate sound coming into both ears. They will tell you that. So she got a left Baha, or she demoed Baha 4 in 17, didn't go ahead at that point, but in 19 she got implanted with a left bone bridge. We ended up having to turn up the sound on it. We ended up having to switch the magnet to a weaker strength because the first one was too strong. It was getting soreness. I tend to go a little strong with the magnets to start out with, again, because I don't want them falling off the patient's head, but then I back off if necessary. We go to the next.
And that kind of brings up the point we were talking about earlier too, with regard to managing magnet strength, because these patients likely aren't coming back for wound care. And at least the mixed and conductive tend to like more the initial activation. Do you find that magnet management has become a primary part of the follow-up protocol for these patients? Just making sure, because if we're activating sooner rather than later, there's still that residual swelling that you're having to work with and through.
Yeah, I've seen that where we've had to go down in strength because there was swelling initially, a little bit of swelling initially, and then it was too strong when the swelling went down. That's happened in a couple of patients. But you know, more it's just a question of, well, it's just a little bit too strong, or maybe it wasn't strong enough. I've had a couple where it wasn't strong enough to at the first guess. But I'd say I probably have to switch magnets in about half to 2/3 of patients that I see going up or down a step most of the time.
Good to know. Thank you.
I think of it like kind of reprogramming a device. You have to do, you're going to do some kind of reprogramming it. You know, I try to get it right the first time, but I'm often not right, or things change. So just quickly with her, you can see her quick sense score. She got 11 dB improvement in her loss with the right ear aided, and 12 dB improvement in her signal noise ratio loss when she was aided in her left ear. So those are great things, and we often see that kind of thing. You can see her ratings of how much speech she was able to understand in situations she identified as priorities for her on the COSI. So she's getting somewhere between 70 and 100% of speech in all of these situations. And she estimated in all the situations were much better than they were, both compared to not using anything and compared to using a hearing aid on one side and a bone bridge on the other side. So just switching from 1 to 2 bone bridges, she thought things were much better also. But she's happy with the devices. I don't know if we can continue with this.
Saul, maybe I can interject here real quick from the surgical perspective, right? I think, you know, a lot of these folks have chronic ear disease that's often hard to manage, right? I mean, they're in this situation because, like yourself, Kevin, had multiple surgeries, you know, have substantial sacral chain erosion, and really it's sort of the last resort. Oftentimes, you know, you're dealing with a chronically draining ear, right, on top of the mixed conductive loss. So many of these occasions we actually close the ears, right? And I think closing the ear canal, some people call it oversewing the ear canal, right? I think oftentimes patients are somewhat reluctant when we first mentioned that concept to them in clinic, but once we've gone through with that, really, it's really so much easier for everyone involved, right? I think oftentimes the questions pertaining to this are mostly, are you going to do it in one stage, right? What if there's active infection in there? Do you actually put the Bonebridge in an ear that has active infection in and all that? So I think those are all really relevant questions. I don't have answers for all of them, right? I think staging is sort of better or safer, but we've had done some a single stage and they're fine, right? I think the critical aspect from a surgical perspective is to get all the skin out of the ear canal, right? Get all the squamous epithelium out, and that's oftentimes, even if you're very, very careful and blind sack the ear canal in a kind of standard fashion, that can be tricky. But I think overall, from a surgical perspective, we've had very, very happy patients who couldn't get water exposure, didn't learn to swim, right? A lot of it is childhood ear disease. Who then we close their ear canal and they go first of all, they have good hearing thanks to your device, but also they sign up for swim lesson. So it's really kind of gratifying to do that. So just my two cents on that particular indication, group of indications, I should say.
Thank you. You guys want to tackle this SSD case study?
I can. I was wondering if you were concerned about the time, but I can keep going if you want.
I think we're wrapping it up. There's just a few more slides. So.
Okay, so this is just an example of a patient who we fit one of these for single-sided deafness. She had a frontal craniotomy for a ganglioma and then had a sudden sensorineural hearing loss 2 years after that. She reported a complete loss in her left ear, although you'll see on her audiogram, I think that's on the next slide, that she does have some hearing in that ear. She did have vestibular migraine issues. She did a cross demo in January of 19 and then a Baja demo in February of 19. And then in June, a year and a half later, she decided to go ahead getting a Bonebridge. So we repeated the SSD evaluation, and then she was implanted in July of 2020. We did the activation in August of 2020, and the vibrogram was shown on the last page there. There you go. I gave her the programs that are shown there. So just this is kind of a standard thing that I do. I usually give them 4 or 5 programs to start out with, and if they're not using them, I take them away if they don't want them there. You can go on to the next slide. So we did her aided testing at a follow-up. I sometimes don't get to it during the initial evaluation because of time concerns, just dealing with other things, but we definitely do it somewhere in there. And I think it's a very important thing to do, like I was saying before. Her aided testing is good above 500 hertz. And this is one thing I'll say, it may be, I think it's intentional programming on the part of the software, but often I get this roll off at 500 hertz for these devices. And patients, though, when I ask them, they like it when I bring that back up. So I'm constantly turning up that 500 hertz gain to try and get it closer to the other ones so that they get a kind of a warmer, fuller sound coming through, which is what they say they want. Her outcomes, again, were very good. She's doing a lot better she's doing either better or much better in all of her priority situations, understanding 80 to 90%, 80 to 100% of speech from her right side, or just speech in general in the situations that she identified as problems for her, including TV in the car, music in the car.
So I believe we've already asked the last poll question. With that,
hey Kevin, before you ask the poll question, maybe just one comment from a surgical side. Obviously, single-sided deafness implantations are a lot easier because you can put the device, the FMT, so the vibration part of the device, into the mastoid of the sonotral angle. It's a lot easier surgically to do that. I think what we've seen is that some folks with migraines, especially like this patient, so I'm glad this patient had a good outcome, but we're a little careful with folks who have a chronic, history of chronic migraines, simply because sometimes they don't like the device under the skin flap, right? So we had some discomfort issues with patients, so to the point where I've had to like remove a device or two for migraineurs, despite the fact that they actually did receive benefit. So just my 2 cents on this kind of topic. I'm certainly glad that this patient loves it and does well, but again, that's sort of a word of caution on my end.
I would agree. I've had patients who complained, the occasional patient who complains about headaches, and they were usually, and this is not just with Bonebridge, it's with basically any of these bone conduction hearing implants. It's a possibility where they just say the device is giving them headaches or contributing to their headaches, and they're more likely to be a migraineur if they if that's going to happen.
But it sounds like some previous history prior to implantation, so definitely something to be considered preoperatively as well. So,
yeah,
cool. Well, thank you. I will turn it back over to Christina to wrap up this afternoon. I believe we're going to open the floor to any questions, but I will let her take the lead.
Hey, thank you so much to the three of you. It was really interesting for us. And I especially like the comment that people start taking swimming lessons because suddenly they can swim because they don't have any difficulties with the ear anymore. I really like that comment and have not been aware of that before. So I think because we are already over time, I don't think we have a lot of time to ask questions. Maybe you can tell me if we have some in the chat. Because I think it's better if we stop. And I want to say thank you very much for to the three of you that you took the time, even though it is quite early in the US. And I want to make people aware that in 1 month, so on the 13th of April, we have the next Experts Online coming again, same time at 3 o'clock. Thank you so much and have a nice afternoon or day.
Thank you guys. Thanks for having us.
Thank you.
Thank you.
Have a great day. Thank you.